We're now going to hear from three experts who have each dealt firsthand with the issues of child and maternal health in developing countries. Dr. Sri Chanda is World Vision's Asia-Pacific Regional Health Advisor. From his home base in Singapore, Dr. Chanda leads a regional team that provides technical support to World Vision officers in 17 countries in the Asia-Pacific region. Dr. Chanda has extensive experience in the design, monitoring, and evaluation of large-scale maternal and child health and nutrition, immunization, TB, and HIV/AIDS programs. Ermelinda da Costa Montero is a midwife and maternal health trainer for East Timor, who's worked for 15 years to safeguard and improve the health of both mothers and babies within her community. For 7 of these years, she's worked as a midwife at community health centers, and for 8 years as an educator and trainer at the National Institute of Health Sciences in Delhi. Moderating the discussion is Ms. Sue Dwala, World Vision Australia's Maternal and Child Health Advisor. Ms. Dwala is a consultant midwife with 20 years experience with a focus on midwifery education. She holds qualifications in nursing, midwifery, child health, sexual health, and education, and has extensive experience here and overseas. So please welcome Ms. Sue Dwala, Ms. Ermelinda da Costa Montero, and Dr. Sri Chanda.
Thank you.
Thank you, Lily, and welcome to everyone. It's great to see so many people come out and talk to us about our passion. So Dr. Chanda, Ermelinda and myself, we're 3 very passionate people, and we're really excited to have an opportunity, I suppose, to share our passion with others, because often as health professionals in this world we talk amongst ourselves, probably more than we talk to the public. So we've had an opportunity to get to know each other today, and we thought we'd start by actually sharing with you a little bit of why we came to this world and what that does for us. So I'd like to ask Chanda first, what is it that made him want to do what he does now with World Vision?
Well, thank you, Sue. 22 years ago, I joined World Vision. I came from a hospital-based clinical emergency and surgical background, and I was invited by World Vision India to visit one of the health projects in a remote desert part of central India. And I went to this hospital where our project was based, and in the compound, there was a lot of commotion and panic, and I was wondering what was happening, and then I found out that there was this skinny, short, pregnant woman in labor that was being wheeled in, and they had just done emergency blood testing of a blood group, and they found out, and they also did a hemoglobin count, they found out that she was only 6 grams per cent of hemoglobin, and that's half of what a normal healthy woman in India would have, which is 12 grams per cent of hemoglobin. So she was severely anemic. She was in labor, and I'm not sure why cesarean section was indicated, but they were going to schedule her for emergency cesarean section. So they're scrambling around to test somebody's blood so that they could get the blood from that person and give her at least 2 pints before they started the cesarean section. There was no blood bank in this hospital. And as I saw the whole commotion, that became, I would say, the turning point of my life, professionally. Because I tried to reflect on the whole situation. I said, couldn't this all been prevented? So I tried to think way back where this woman came from. Probably her mother was also short, skinny, malnourished, anemic. And when she was born, she was probably of low birth weight, like 1/3 of all newborns today in India, even after 20 years. The low birth weight means below 2.5 kilograms at birth. And because her mother was poor, she probably was left alone, was not properly breastfed, didn't get all the complementary feeding when she was 6 months old, never had a chance to go to school, that's why she was illiterate, and was deprived of all the life skills training as a young girl. And she was probably married off very early, and as a married woman, she was not an independent decision maker. She was probably beholden to her mother-in-law and her husband, so had no much rights of her own. And her first contact with the health system was on that day. So for 9 months of pregnancy, she never had tetanus toxoid injection, she never had iron folic acid tablets that could have prevented anemia or at least reduced the anemia. And here we are. And I realized that prevention is cheaper than cure and better than cure. So that was the turning point of my life.
And I think as medical people, we often think that hospitals and clinics are going to fix the problem. And you've probably seen Rebecca's video as being compelling. But some of what we're talking about tonight is actually that things can be done outside of the clinic. What's really sad about Chanda's experience in India, which is it is a long time ago, is that maternal mortality has not changed. So we haven't fixed the problem yet, and we've got a long way to go. And prevention is one really important way of doing that. And our Child Health Now campaign is actually trying to focus on what else organisations can do, like ours, to work at the community level. And to try and help women understand why, and their families and their communities, why anemia, for example, needs to come being fixed early in life. It's something to do with the whole generation. So look, thanks Chanda, it's something about the lights go on for us. And Ermelinda, she shared a little bit with me about why she became a midwife, and it's a really interesting story, and it talks about a whole family and the same generational issues. So I'd love to ask Ermelinda to share with us, why did she become a midwife?